Stephen Vold from Vold Vision in Fayetteville, Arkansas. And I had the great opportunity to present about surgical pearls in glaucoma surgery for angle closure patients. And there's just a few things that I'd love to share with you today that I found very helpful in my practice. First of all, for patients with angle closure, whether it's angle closure glaucoma or just appositional angle closure, and some just with angle closure where there's synechia but no glaucoma, really one of the things that I really think is helpful intraoperatively is taking out the cataract. By opening up the angle, by removing the cataract, not only can we improve the quality of their glaucoma care, but we can improve their visual outcomes. And a lot of these patients, especially when they don't have any optic nerve damage, they're really good candidates for extended range of vision lenses. So really, cataract surgery, think of that first. Now, people that have over 180 degrees of peripheral anterior synechia, I really like to utilize the technique we call goniosynechialysis. And what we can do this in a number of different fashions. Some people will use kind of a little microforceps or a micrograsping instrument, and you can make multiple little paracentesis sites, and we do this under gonioscopy a lot of times, and we'll use an indirect gonioscope, and we can literally tease the iris out of the angle, break the synechia, and open up the angle. One of the things I think is really helpful with that is making sure you're out in the very far periphery, because you don't want to tear the iris, and we don't want to disfigure the iris either so the pupil doesn't function as well. I actually personally, to avoid using multiple incisions, I use an automated irrigation tip it has a polymer tip on it, which allows me to just go through the cataract wound and then gently tease the iris out of the wound. And I found this to be a very helpful pearl to open up the angle. In people with more severe glaucoma, let's just say they've got very advanced glaucoma with chronic angle closure, you may need to perform a trabeculectomy. If they have a cataract, I really recommend to take that out at the time of surgery. And one of the key pearls with this is really use tight sutures, especially in the early postoperative period, because otherwise you may end up with a ciliary block glaucoma, or what we call aqueous misdirection, or some people have known as malignant glaucoma. Tight suturing is really important, and I found early on in my career is that if I can get their cataract out, really that makes for a much smoother postoperative course. And then the last thing, occasionally you'll run into patients with nanophthalmos where they have a really, really short eye, and they're prone to getting not only angle closure preoperatively, but even during surgery they can get uveal effusions, and they can develop aqueous misdirection postoperatively. And sometimes if they have a PI, you can just anteriorly just make a little break in the posterior hyaloid face. However, I need to be careful because you don't want to go too posterior, because oftentimes the ora serrata is a bit anterior, and the last thing we want to do is cause a retinal tear. But then in the postoperative period, earlier than later, a lot of times I'll do a YAG capsulotomy, making sure I break the posterior hyaloid face, and that will deepen up the angle. So in summary, there are really four things that I've kind of learned as take-home messages. Number one, cataract surgery is a big deal early on, can really avoid some of the complications of glaucoma later on. Number two, if there is anterior synechia, especially over 180 degrees, goniosynechialysis is a great tool in helping treat angle closure and avoiding other procedures. Number three, tight sutures for trabeculectomy. And then lastly, for people that have shorter eyes, and remember, angle closure are a little bit more prone to aqueous misdirection. If you need to, you can break the hyaloid face with the laser, or even potentially intraoperatively through a peripheral iridectomy.